We've got 4 good-looking papers on contextualizing mortality. I'm going to introduce the speakers with each paper. Beginning the session with a paper titled Long Run Effect of Radiation Exposure on Mortality is Yuqing Han. She is a PhD candidate in economics at the University of Illinois at Urbana-Champaign. She's an applied microeconomist with broad interest in environmental economics, labor economics, and health economics. Her research leverages large administrative data sets and causal analysis methods to investigate the social costs of environmental pollution and the effectiveness of regulatory policies. So, Yuqing.
Hi, everyone. Thank you so much for David's introduction. I'm Yuqing, and I'm now on the job market. This is my job market paper, The Long-Run Effects of Radiation Exposure on Mortality. So we care about this question because nowadays we still face the risk of radiation exposure from different sources. However, it's an important question: how bad are the effects on health, and what are the cumulative consequences? You may think this should be a well-studied question, but actually it's not. Especially because the low-dose radiation exposure do not have immediate health impact, but it may delay for many years, especially on mortality. So why it's not well-studied? Because of 2 challenges. So first, we need a natural experiment that happened really long before to observe the decreasing. So the Chernobyl and Fukushima are too close to nowadays. And for the atomic booms in Japan, a lot of things happen at the same time. So there are a lot of confounders on mortality. So it's also hard to clearly answer this question. Also, we need to link the individuals over a very long time period to observe the birth record and the death record. So I look back into the history and find the nuclear weapon test during the 1950s in Nevada provide a natural experiment to answer this question. So basically, there are about 100 atmospheric tests happening in Nevada, and each of them can generate some radiation fallout which can travel across the whole US via the prevailing westerly wind. And those fallout can down to the ground via precipitation. So this paper focusing on the iodine-131, which is one of the most harmful radiation fallout to our human body because it can absorb by thyroid, which is a very small organ behind your neck, and then continuously affect your health in the future. So the right-hand side figure shows the overall radiation fallout of iodine-131 during the whole nuclear weapon test age. Well, you can see that the distribution of those fallout is not really random. A county in the Midwest that are closer to Nevada can have larger radiation fallout than a county in the East Coast. That's obvious. But the within-state variation depends on weather condition, such as wind direction and precipitation. So that means if there are more rainfall, people can expose to more radiation during that time. So by comparing the counties within the same state, we can have a quasi-random variation. Okay, except for the overall variation, since there are a lot of years and there are different tests, different scales, and different time of those tests. So for each year, the radiation fallout distribution is also different. So that's provide a random time variation. And this figure shows how people can observe those radiation fallout. So basically, after the fallout travel arrived at those place, and the cow who eat those fallout can produce collected milk, and people who drink those milk can collect thyroid in their can collect iodine in their thyroid. So this sighting provides a unique opportunity to answer those 3 questions. So first, does those radiation effect can affect mortality after 40 to 50 years after those first exposure? And second, does those effects vary by age? And third, what are the impacts of prenatal exposure? So the data I use is the linkage of longitudinal international electronic microfile with the 1940 census. And then I linked to the radiation fallout data I observed. So for the identification, I use different model for the exposure at different life stage. So I'm going to talk about more later. So that's what I find, overlook. Basically, I find that there are negative effects of radiation exposure on longevity. So the children and elders are more sensitive to radiation. If the exposure happened before age 15, the life reduction is about 16 months. And if it is happened after age 60, the life reduction is about 30 months. And the effects on young adults and middle-aged adults is not really significant. More importantly, I find delayed effects, especially for the youngest cohort. Those deaths are increasing only after age 55, which emphasize the importance to estimate the long-run effects. And I also find negative effects of preconception exposure on future mortality, but actually is a bit moderate than the after-birth exposure. Okay, so this is the how this paper linked to the previous literature. I mean, now talk about that. So first, this paper is related with the literature about what's the effects of radiation, and it's also related to a broader literature that estimate how the early life condition affect the future outcomes, also related to the economics history paper. So this is the data I used. So the longitudinal international family electronic macro data include vital records in Ohio and North Carolina. So the information I use, including the birth, death, and the family structure. So for the after-birth exposure, I use a cohort who born before 1940 and still alive after 1950. Since this cohort can link to the 1940 census, so I can know where they live before those tests. And for the before birth exposure, I use the cohort who born between 1951 to 1970. So for the residing counties, I use the 1944 count census. Also, this data provide the controls and all of the covariates I need. For the radiation fallout data, I use the National Cancer Institute fallout estimation, which provide a county level fallout of 84 states in continental US between 1955 to 1970. And for the after-birth exposure, I use a yearly variation of fallout. And for the before-birth exposure, I use the monthly variation. Okay, here is the model about the after-birth exposure. In here, I use a generalized DID model where I compare the individuals who born in different counties and those who exposed to radiation at a younger life versus older life. So the variation becomes the treatment, which equals 1 if the radiation fallout is in the top 60% over the whole US, and 0 if it's in the lowest 40%. By including the state-by-birth fixed effect, the covariates of those treatment and control group are really balanced. And for the yearly variation, I use an indicator which equals 1 if the individual I exposed to those first exposed to this radiation at age group A, and the age group is separated by every 5 years from 11 to 60. And here shows the results. You can see that if a person exposed to radiation during 11 to 15 years at the first time, the life reduction is about 15 months. And for the elder people who exposed to radiation after age 61, the life reduction is about 30 months. Now another question comes, especially for the younger cohort. When did they decrease? Did they die immediately or did they die after many years? So I do the same regression with another outcome variable, which is whether an individual alive at a certain age from 20 to 60 years, separated by every 5 years. Then I do the regression multiple times and plot the coefficient for the youngest cohort. And here shows the results. The increase of deaths is only becomes significant after age 55. So that shows a significant delayed effects of radiation exposure. And also, I look at what is the prenatal exposure. How about that affect the future mortality? In here, I use the monthly variation. The outcome data is whether an individual is alive at a certain age, and the treatment is the fallout in each 3 months before birth. And except for the county fixed effect and birth time fixed effect, also include the sibling fixed effect, so we can control most of the unobservable factors at the household level. And here shows the results, like the x-axis is coefficients, and the y-axis is default, like 1% fallout increase in each 3 months before birth. And you can see that across all the life stage, only the radiation fall in 10 to 12 months before birth have a significant effect on future mortality. And here shows the effects like over all ages from 0 to 50. You can see that like those coefficients are slightly increased, but not a lot. Probably because the radiation fall during that time is actually very low for those newborns. So most of the mortality happen at younger ages. And for the elder ages, definitely that's a case. A lot of deaths we cannot observe, but for the younger ages, it should be robust. And I also did a lot of robust checks, so if you are interested, we can talk about that during the breaks of the future discussions. And that's my conclusion. So basically, I find the radiation fall can negatively affect mortality, even if you're living in the places that are thousands of miles away from those where the nuclear boom happened, and it can also affect your mortality in many decades. Also, I find the children, elderly, and women, are most sensitive to those radiation fallout. And now we are doing a new project about what are the subclinical effects of prenatal radiation exposure, working with Professor Douglas Elman and Professor Joe Ferry. And in here, I'm working in the RDC to merge the Newman file with the 2000 long form and the following ACS to look at how those prenatal exposure can affect income, employment, labor force participation, and occupation. And that's all about my presentation, and thank you so much for listening. Yeah.
Excellent. Our next speaker is Leonardo Urrea, here from the PhD student in economics at the University of Pittsburgh. You can come on up here. Specializes in macroeconomics and development. His research focuses on economic policy, development, and quantitative modeling, drawing on some professional experience at Colombia's Ministry of Finance, the Inter-American Development Bank, and Academy. He's written for several media outlets and founded the Macroeconomic Division Analysis at Universidad Nacional de Colombia. So,
okay, you have time. Okay, hi everyone. I'm very happy of being here. Thank you for the amazing presentations we have seen here. I can't wait to talk to you. This project is the evolution of my second year paper. When I analyzed the mortality consequences of an economic collapse in Colombia in the Asian financial crisis. So, what do we know about the relationships between economic cycles and mortality, specifically recessions? We know that in advanced economies, the mortality rates are procyclical. So when the economic activity goes down, the mortality rates goes down. Why? Basically, because fewer work-related accidents reduce pollution. There is a recent paper by Amy Finkelstein in the Quarterly Journal of Economics. But my point is that the possible increases in mortality are counteracted or mitigated by robust safety nets. So in advanced economies, you have cash transfers, non-contributory pensions, unemployment insurance, and healthcare access, which maybe is not true in the developing world. So we do not know the effects of economic crisis in countries that do not have robust social safety nets. So in developing countries, we have that shocks are deeper and more frequent, and we don't have the data to work on that. So in this project, I decided to build the data, like to go to the statistics department in Colombia for 3 months in 2 computers with just 10 gigabytes of RAM and build the data. And I would like to continue this agenda because the regulation is awful, and we need to promote that agenda to make this information more accessible. So I find that the mortality exhibits a countercyclical behavior. So it's the opposite of what happens in the US. And you can expect that. People starve, people is affected by malnutrition, by stress. I remember my dad lost his job in that crisis. And I remember that we changed our diet. So I had this experience, and thanks to life, my mother was a public servant, so we were protected, but many people were not. So we find that the crisis led to a sharp increase in mortality, particularly among vulnerable groups like children and the elderly. So we find the opposite effect that in the US is an increase in the mortality rate. And by age group, the most affected were in utero babies, like involuntary abortions after the week 20, 0 to 1 human beings, prime working age population, and senior persons in retirement, people in retirement age. The key causes of death related to the crisis include perinatal conditions, nervous diseases, and external causes. I'm finding like increasing suicidal and homicides. So I think that that's something that we don't see when you have a safety net. So this research talks to how important are safety nets to protect human beings and economies. So if you are doing a fiscal adjustment, maybe you shouldn't touch the safety net like Medicare or right. This is the crisis. I don't have time to go over the crisis. And this is the potential GDP. This is the potential GDP. So you see that it's a structural change, but you have two features that the crisis has. Is one, it was externally triggered. It started in Thailand and Asia, and it widespread to Latin America. And two, it was unexpected. So the economic authorities, local and international, IMF, World Bank, they didn't see that coming. So they underestimated that. So there was no strategic behavior to anticipate that, which allowed me to say something about the causal identification. That I promise this is an interesting question. I'm not upset with causal identification, but I need to do what is possible. This is what I did. At first, I just plotted the under 5 death rate, and I saw this, and I was like, oh, okay, I need to see if this is caused by the intensity of the crisis or not. So I went and built this mortality dataset. So I built this mortality dataset that has data for 8 million people who died between 1979 and 2022. I have age, cause of death, and geographical information of municipality and state of residence, not just death. And I built a dataset on pregnancies, 6.2 million pregnancies events, including newborns and fetal deceased. Between 1998, and that is just the year of the crisis. So in this dataset, I don't have a pre-trend, but I still can do some analysis. And here in the pregnancy dataset, I have demographic, socioeconomic, and geographical information. So I can say something about the background. For the economic activity, I use national and regional accounts of the Department of Statistics of Colombia at the state level. And to explore the importance of safety nets, I built this public health insurance dataset. So I have data for each municipality since 1994, that how many people in each municipality has health coverage, has health insurance, public or private. So I can explore this evolution on the coverage of the health, like which municipalities had more coverage as a percentage of the population and which ones were not, because the health system was very new at the moment of the crisis, had just 4 years. It was a new system in 1994, so the system was just 50% coverage at that time. So this is the variation I will use. The GDP shock affected the country differently, and the mortality rate was very heterogeneous too. I'm using a fact for causal identification is that these two numbers are not correlated pre-crisis. So that's something that helps me to identify the effect of the shock. I have this mortality by cause. I will go over this later. So as I told you, my empirical strategy relies on the unanticipated nature of the shock and the differential exposure to the shock. So I will use that to build this model. I want to spend a lot of time here. I just have the Y is the adjusted mortality rate, um, and a dummy variable when I have the pregnancy data set. Because in the pregnancy data set, I have zeros and ones. I have the total number of pregnancies, and I have which ones were the ones who died. So I have that. And the shock is just one-time shock from 1997 to 1999. I have how much the GDP collapsed. I don't have unemployment data. Sadly, this is a research agenda that needs to continue. We can build that, but we need time and hands. I used fixed effects by state and year. This is a continuous event study. Here you can have like the pre-trend of the above. So I organized the population in the above median affected by GDP collapse and the below median affected by GDP collapse. And I saw that, okay, they were trending before the shock, they were trending kind of parallel, right? I need to defend that assumption to see something about the causality about the shock. So this is the headline result. I find the opposite result of what Finkelstein and others found for the Great Recession. The mortality rate, the age-adjusted mortality rate, in fact, increased. And when I distribute this with female, male, I found that what the literature has found is that male died more, right? Male human beings died more. I decompose that by age. I have these four, the blue bars are the shares of deaths before the crisis, and the purple ones are the estimated contributions of the overall mortality rate increase. You have 0 to 1, working age population, and humans in retirement age. This is the result for the fetal mortality dataset. So I don't have a pre-trend, but I found what I was expecting, is that this is landing. It starts very high. This coefficient is how much the mortality rate increases per percentage of economic collapse. So you have that, and I did a reverse event study. So this is compared to the 2007 mortality rate. When I distribute these by socioeconomic variables, I found the opposite of what the paper in the US found, and it's the most affected ones were the high school or less, so the more vulnerable ones. So that's what I was expecting. And the male died more, and there is a huge literature that in health. When I look effect by cause and age, I will speed up because I want to show you some effects by cause. I found that external causes in the working prime population are important. So I zoom in there. I was like, okay, which ones are these external causes? I did some robustness checks. So I found that stress is a plausible mechanism. This is the raw data, right? This is not the estimation. When I do the estimation, I found a persistence in suicidal rates. So this crisis was a triple crisis. It was an external crisis, was a financial crisis, and that generated a housing crisis. So I found anecdotal and press evidence that people just killed themselves because the debts, because of the interest rate raised, the houses were valued less than the debt. So that was, and this is the first paper that documents this. Again, we can try to test this in other countries. There were 11 or 12 countries affected by this crisis. I did this health insurance specification. I organized the municipalities from high coverage in public health insurance to low coverage, and I just interact that to see if the public health insurance is an attenuator of the crisis. And I found that, yes, in fact, indeed, that's the case. If you're in the quartile 4, right, the highest quartile of coverage, you have a lower effect of the crisis. So this health insurance matters a lot, specifically when you have an external shock that comes from the sky. Okay, I can just do that. Okay, I want to do some closing remarks. This is a open agenda. This has been a very difficult agenda because of the data availability. We need a lot of hands. We can do some causal inference, macro and policy papers, but we need to be more people doing this. So my invitation is to do that. I'm trying to do a welfare calculation to see how much money we could have invested and prevent this loss of human beings. Specifically in Colombia and Latin America, that is a region that is losing population at a very high speed. So we cannot allow like countries to lose entire cohorts just because we don't have a robust safety net. No, I'm happy to answer questions, and I can send you the draft. Not today, in 1 month. I need to finish the welfare calculation. Okay, thank you very much.
Okay, our third paper is Co-Resident Grandparents Mobility Risk and Racial Ethnic Variations. It's by Dr. Hongwei Xu. He's an associate professor of sociology and the director of the MA program in data analytics at the City University of New York, Queens College. Andrew Beveridge is home, right? No? Yes. Yeah, this recently, so we'll be missing Andrew. So take it away. Well, I should have said his research interests include social and environmental determinants of population health and aging.
All right, thank you so much. It's very excited to come to a conference with data geeks. This is a collaboration with John Logan, who is my long-term mentor, and Todd Garner. I didn't know Todd would come because last year I invited him to the same presentation at the Social Security Administration. He declined. That's why his name is not appearing in the agenda, but I always include him on the slides. Standard disclaimer, nothing to do with federal agency whatsoever. Okay. So millions of American grandparents surprisingly actually live with their grandchildren. And some of them are even primary caregivers of their grandchildren. These are known as co-resident grandparents and custodial grandparents in the literature. In 2021, for example, about almost a third of these co-resident grandparents, they were responsible for the basic needs of their grandchildren. And among these so-called custodial grandparents, nearly half of them had performed such a role for 5 years or even longer. Something unimaginable. As a, yeah. Anyway, so just to give you a little bit more concrete background, this graph shows the percentage of US adults aged 50 years or older who were co-resident grandparents from 2000 to 2023. As you can see, there's a notable racial ethnic difference. Hispanic and Asian Americans were much more likely to live with their grandchildren than blacks, who in turn were more likely to live with their grandchildren than whites. The second graph shows the percentage of adults aged 50 years or older who were custodial grandparents. Hispanic grandparents were still more likely than others to be custodial grandparents, and white grandparents were still the least likely to be custodial grandparents. But Asian Americans, although they were more likely to live with their grandchildren, but they were very unlikely to be the primary caregivers of their grandchildren. And the Black Americans, they were less likely to live with the grandchildren, but once they live with the grandchildren, they were actually much more likely to be the primary caregivers. So the top two graphs shows the trend over time in terms of prevalence rates. As you can see, there's kind of like a declining trend. The bottom two graphs shows the actual number of co-resident grandparents and custodial grandparents over time. So even though the prevalence rate is declining, but because presumably the entire American population is aging, so the number, the sheer size of co-resident grandparents and custodial grandparents are actually increasing over time or staying relatively stable. So in this study, we want to study the health consequence or mortality consequence, to be specific, of living with and caring for grandchildren. There's a long literature debating about how looking after grandchildren could affect grandparents' economic well-being, physical health, emotional well-being, so on and so forth. There are competing theories. The low string theory predicts, being a caregiver in old ages for grandchildren could be harmful, while the low enhancement theory predicts the opposite. So I'm not going to get into the theoretical background too much. Basically, in this study, we want to estimate the mortality risks for grandparents who live with grandchildren or being the primary caregivers of their grandchildren. And we want to focus on the racial difference across 4 groups: non-Hispanic whites, blacks, Hispanics, and Asians. I'll skip this for now. Maybe you'll come back in Q&A. So we're not doing causal inference because we haven't figured out how to deal with selection into this living arrangement or caregiving arrangement yet. So we're just doing plain old and simple demographic research by carrying out a survival analysis. We measured grandparenting status in the 2000 census long form. So that's our main predictor. We use mortality information from the numerator file for the period between 2000 and 2019, so right before the pandemic. We link the people from the census, 2000 census, to the numerator file thanks to the, a miracle project called CLIP, which I guess the Census Bureau created this so-called protected identification key, which is a special ID that allows us to link people across different data sources. So we restrict our sample to 50 years or older as of the 2000 census. In the census, 3 questions were asked about their living arrangements related to grandparenting. So those are the 3 questions from the census form. Our outcome variable is time to death, measuring days from April 1st of 2000, that's census day, all the way to December 31st, 2019, which was the time of the right censoring. And because the numerator file does not provide cause of death, so we are looking at just as time to death, time to all-cause mortality. So our main predictor is this multi-categorical variable, which we can collapse 2 groups. So we have a reference group. These are the people who did not live with their grandchildren. The second group is those who live with grandchildren but were not the primary caregivers of the grandchildren. So in this study, we refer to them just as co-resident grandparents. Then we have 4 groups of custodial grandparents, depending on how long they have performed this caregiving role, from less than 1 year, between 1 year and 2 years, 3 years and 4 years, and 5 years and longer. So all our control variables and predictors were measured at the baseline, the 2000 census. We estimate 2 models for each racial ethnic group. In the first model, we just control for age and gender and static fixed effects. In the second model, we control for what were available in the census form, such as household structures, socioeconomic status, acculturation. This was particularly important for Hispanic and Asian grandparents, and the disability status. Okay. So this just showed the crude death rates. So basically the percentage of people in our sample who died between 2000 and 2019, broke down by racial groups and their grandparenting status. I think the 2 main findings in this descriptive picture is that custodial grandparents were not necessarily more likely to die, and Hispanic and Asian older people had lower crude death rates than whites and blacks. So these are our main results. It's estimated hazard ratio of mortality risks. The numbers highlighting or colored in red are significantly higher risk of mortality, so to speak. The numbers colored in green are significantly lower risk of mortality. Anything else are not significant or just control variables. So in the first model, we see that for, unfortunately for white co-resident or custodial grandparents, the mortality risk was significantly higher compared to the reference group. For blacks, being a short-term custodial grandparent was associated with lower risk of death, while being a long-term custodial grandparent, meaning 5 years or longer, was associated with high mortality risk. For Hispanics, being a co-resident grandparent or short-term custodial grandparent was associated with lower risk of mortality, but being a long-term custodial grandparent was associated with a higher mortality risk. For Asian grandparents, being a co-resident grandparent or I'm going to say short-term or mid-term custodial grandparents was associated with lower risk of mortality. Once we control for all these other baseline characteristics, the direction of the association remains the same for whites. So basically, being a co-resident grandparent or custodial grandparent for whatever duration of time were associated with higher risk of dying. For black grandparents, being a short-term custodial grandparent was associated with lower risk of dying. For Hispanics, being mid-term or long-term custodial grandparents were associated with high risk of mortality. For Asians, being a co-resident grandparent or mid-term to long-term custodial grandparents was still associated with low risk of mortality. So to conclude, we found a notable regressing difference in association between grandparenting status and the mortality risks. For whites, we found a consistently higher risk of dying for being a co-resident or custodial grandparent. For blacks, we found a reduced risk of mortality if they were short-term custodial grandparents. For Hispanics, there was a significantly higher risk of dying for long-term custodial grandparents. For Asian American grandparents, luckily, being a co-resident grandparent or even long-term custodial grandparents was associated with a lower risk of dying. So I'm going to conjure funding from my college and the Social Security Administration. And thank you for listening. I'm looking forward to a Q&A. Thank you.
Fantastic. Our last paper is titled Big Data for Health, Understanding Working Age Mortality at Very Fine Spatial Scales. And presenting that paper will be Myron Gutmann, University of Colorado. Myron, I think many people know him. He's had a long career studying historical and contemporary demography and serving in leadership positions at ICPSR, the University of Texas, University of Colorado, and at the National Science Foundation.
Thank you. This is a kind of a new data set. So I'm going to spend a fair amount of time talking about the data and then if I have time, I don't think I will, but I have time to talk a little bit about just a couple of quick things that we've begun to find. I have a big team of collaborators, faculty, postdocs, graduate students. This is funded by NIA, supported by our Population Center, with lots of thanks to state departments of health, including the state of Minnesota, where we are now. Everyone wants to be thanked. Everyone wants us to say that it's our fault and not theirs. And I welcome that opportunity. One of the things I will tell you is that we've worked with a lot of state health departments on this project, and they are unfailingly helpful in even challenging moments. And we started this in 2022 when the COVID crisis was really just wrapping up. And it's been amazing to work with all of them, even the ones that are a little bit less helpful than the others. So here's the problem. There's been a rapid increase in mortality in midlife Americans since the 1990s, what Case and others have called deaths of despair. And the question really to be asked is, how are you going to analyze it? And there's a big National Academies report. NIA put out a call for projects to look at this. And so we proposed a project to study midlife mortality at the finest scales possible. And this chart of map of New Jersey mortality really reveals the scale of the problem. The left panel is county level data, and it shows the interquartile ranges of mortality. And it shows you that there are basically hot spots and cold spots of this. And then if you dive in to specific counties, the top right panel is Essex County, which is Newark, and you have some, this is actually mortality, midlife mortality, crude midlife mortality rates. The top right panel is Essex County, which is Newark, and you see this deep hot spot of high mortality around the city of Newark, spreading out to much lower mortality in the suburban areas. And that's because Essex County contains not only Newark, but suburban areas that go way out into not quite rural Western New Jersey, but into areas that are not very deeply populated and are quite prosperous. Mercer County is Trenton, but also that other great urban metropolis, Princeton. And it has exactly the kind of attributes that we're talking about, in which, and basically the bottom line of this is that a county, which is how most of our public mortality data are reported, are simply not the right measure for a lot of things. So what did we do? We proposed a study, foolish us. We proposed a study to study individual death certificate, to start with individual death certificates with residence information at the address or at the latitude and longitude or at the census block. Different states keep their data in different ways, and trying to look at different approaches to analysis. There are no easily accessible national data sets with this scale of geography that can be used outside of the RDC or the equivalent environment. And so getting the data required a request to every state. In my written paper, I talk a fair amount about sort of the various approaches, but basically there are states that don't have the data. There are states where the data are public. Minnesota is one of them. There are states of the data where you have to request the data and prove your bona fides and prove you're going to keep them securely. Some of these data are free. Some of these data are extremely expensive. Everyone requires many states require then that you can't publish anything without getting their prior approval for it. We've decided to go along with those requirements. Our experience so far has been really good. In the 6 states that I talk about for the paper today, only Michigan has a strong prior approval requirement, and they turn around our requests even for a long paper in a few days. So that's not been bad. Every state has a different process. Some of the processes are automated. Some of them are manual. Some of them are quick, and some of them take a long time. It can be a year before we get an answer to an email sometimes. Everyone wants to know what we're going to do. Everyone wants to know what the data elements are. Everyone wants to have human subject documentation, and everyone's approach to human subject documentation is different. They also want to know who we are. They want to know how we're going to protect things in terms of people and in terms of technology. We're good at this, but everything. I spent a whole year writing data requests, but we did it. This map shows the distribution of the data we have now. We're still waiting for Kentucky to actually come up with the data, but we have data for 14 states. The green ones are ones that start around 1990. The blue ones are the ones that start around 2005 with detailed residence information. NCHS did not really require states to digitize residence in detail until the mid-2000s, which is why many states don't have those data earlier. Some states don't do it very well or do it quite a bit later. Iowa's around 2011. Maine is about 2015 or 2016. But in the end, 7 million deaths. So a fair amount of information to record and a lot of information. We think there are about 250,000 Oklahoma deaths that we haven't fully processed yet. So a little bit more than this. It's a fair process to bring the data together because not only does every state handle it differently, but every state has a different coding scheme, and many states have 4 or 5 different coding schemes over the last 35 years. And so everything has to be harmonized. The data, the location data have to be geolocated. and they have to bring together into a set of things. The more we dig, for example, into cause of death data, the more we learn that, well, they didn't quite get ICD-9 quite right the first time, and they left off the leading zeros that are critical to ICD-9, and so, well, could you go back and convert your SAS files differently for us? But everyone's been good about this. We have as of now, all of the data. But we also lived in kind of a little bit of a fantasy world in which we thought we would start with block level data. Blocks are really too small. Counties are too big. What do we do? So the problem with block data, there are two things. One is that they're too small, and the other is that when you geolocate a residence address onto a block, you often wind up in the wrong block, it turns out. Something like between 5 and 7% of the time you wind up in the wrong block. If you consolidate to smaller blocks and you do a little bit of magic, again, we have a paper that's just about to go out to submission to journals about this particular problem, you can solve it. Block groups and tracks avoid most of the errors of misplacement, but also have populations that are a little bit on the small side. What we've been doing, and I'll show you in a minute an example, is that we've been clustering block groups together by similarity, which has had a lot of success, and I will get something through in 5 minutes. We use, thanks to NHGAS, we're basically isolating everything on 2010 census boundaries so we could have consistency through time. We do this clustering with the MaxP algorithm. I won't go into detail about that. It works. The clustering looks, I'm sorry how faint this is. Well, and I didn't show it on a big screen. You would see that it clusters beautifully. We also have a bunch of other sources, obviously census data. We use the NETS business establishment data to look at the nature of business. One of the hypotheses in a lot of the midlife mortality world is that there is functions related to the presence of food supply, the presence of sales of alcohol and guns, and all of that is accessible to us through this business establishment data, hundreds of millions of cases. We're interested in mobile home parks. We're interested in crime reporting. We're interested in toxic inventories. Emily Parker and Laura Tash have this wonderful data set of federal government expenditures that help us. So anyway, that's the data set, and I have about 3 minutes to show you a couple of examples. One example I'm going to show you is cause of death, and again, my colleague who makes these has never seen a bright light she doesn't like. But what this shows you, the interesting is this is really about sort of the increase do I have a mouse? I have a mouse. This is the increase in homicide. This is COVID. This is Colorado. This is the decrease that's parallel with COVID in cardiometabolic and cancer diseases. Lots of interesting things here. These are state scale data. Here's parallel data that we've gotten for California and New Jersey, very similar outcomes. Interesting thing here for you to see is this is the decline of AIDS. And you can see just how much information there is in these data sets when you get down to cause. Let me show you just one other little thing to show you some of the things here. So one of the things we've done, this is based on work that our colleague Dylan Connor has done, is looking at trajectories that states that go through. This is sequences that block group clusters go through over time. So this is reducing the data, starting at a very refined spatial scale, very, very dramatically to show trajectories through time of change. And it shows that there are places, if we look up here in the upper left, that are low through the whole time period. And there are places that are high through the whole time period. And then you can identify different clusters of spatial units. This is one that goes from high to very high. These are men and women together. This is one, if I can face it, that goes where men drift higher, but women don't. This is one where there's a very rapid increase. And this is one where the women increase. And so we can do that, really boil down the data starting with high spatial scales. And then the next step on this, obviously, is to go through a multinomial logit process to try to understand what are the attributes that identify these things. One of the things you should ask first is, at the broader spatial scale, what's happening at the level of the state? 6 states here. If I can remember them all. Oh, these are 4 states where you have the whole time period: Colorado, Florida, Massachusetts, and Michigan. And you have 2 very distinct patterns here. And that alone is interesting from the beginning. We have high mortality states, which is Florida and Michigan, and low mortality states in this case, which is Massachusetts and Colorado. These represent very different socioeconomic trajectories in this time period. Michigan is declining manufacturing. Florida is broader societal change. Colorado is fitness for everybody. Massachusetts is early establishment of better public health insurance. So a lot of things going on here that you can start from very small units of space, avoid the problems of characterizing Essex County, New Jersey as one averaged out thing, and get to some really interesting results. And I did it in 13 minutes and 47 seconds, according to this. Thank you.